So thank you for the lovely introduction. As already explained, I'm working as a clinical psychologist and National Specialist CAMHS OCD, BDD and related disorders service at the Michael Rutter Centre in London. And this morning I'll be talking to you about understanding and treating BDD in young people. So just to give you a bit of an overview of what we'll be covering this morning, we'll be spending some time understanding what BDD is and understanding what some of the most common symptoms of BDD are. So thinking about some of those worries, some of the behaviours that we come across quite commonly. We'll also then move on to thinking about, sorry, that jumped there. We'll also move on to thinking about how to access help for BDD and what to expect from the assessment and treatment process, and really focusing on CBT for BDD and what to expect from that treatment. So what is BDD? And I'd like to start off by sharing, to start supporting understanding this question a bit better, a video of a young person who was assessed and treated in our service, and talking about his experience and treatment process with BDD. Again, at the beginning, this young person shares quite difficult experiences of his BDD, so you may want to step away from the screen in case this is something that might sort of bring some difficult memories up.
Elif, there are a couple of messages coming through that because we can't hear any sound.
Oh, okay. I'm so sorry.
That's okay. There's a couple of messages in the chat box.
Is that for everyone or?
Yeah, so yeah, I can't hear it either, and I think a couple of our attendees can't. So I don't know
Okay.
if there's maybe an option when you go to press the play button within your PowerPoint.
I think it's, sorry about that. Is it starting now? I don't think it's giving an option to, the microphone is, sorry.
That's okay. We can't hear anything at the moment.
Is it the same now?
Yeah, it's still the same now.
I'll just quickly, I don't know if.
Hello, I was just wondering that if the link's available, perhaps we could put the link in the chat and people could have a look on their own time, maybe.
Yeah, I think that's a good idea. I can't see an option, I'm afraid, to add the sound here. So what I might do is pop that in the chat afterwards, and yeah, people can have a look in their own time. I'm really sorry about that.
No worries. No, that's a great idea to pop it in the chat.
Okay, brilliant. And I can make sure I put that in there afterwards.
I can give a reminder at the end if that helps.
Yeah, that would be brilliant. Thank you. So I'll quickly switch to my next slide, and what the video basically covered, which hopefully you'll see when you're able to view it in your own time, is that it really helps us understand sort of some of the main features and what BDD can involve and what BDD is about. And this young person in the video would be talking about spending an excessive amount of time worrying about his appearance, and BDD typically involves spending a lot of time worrying about a perceived flaw in appearance, and by a perceived flaw we mean flaws in appearance that other people can't really see or generally wouldn't notice. And in order to sort of, in a way, sort of correct or fix this appearance flaw, young people can find themselves carrying out lots of behaviours or things like mental acts. So it might be that they're doing lots of makeup routines, wearing excessive makeup, wearing lots of specific types of clothes to cover up their physique, for example. They might find that they're completely avoiding going out to certain places or seeing certain people, or completely stopping leaving the house and feeling pretty isolated. In terms of mental acts, they can be things like comparing their appearance to people that might be sort of they're seeing on the screen or walking down the road. So it can take quite a broad range of certain mental acts that we can cover later on in our talk. What we know is that BDD causes a considerable amount of distress and really gets in the way of daily life and daily activities, things like being able to go to school, socialize with friends, spend time with family, and lots of people can also describe stopping doing the things that they used to enjoy as well. So we know that the impact and the distress caused by BDD is really, really great. Another thing that we know about BDD is that appearance worries are generally not related to worries around being fat or weighing too much, and typically not affecting eating patterns. It's not unlikely that someone might have worries around their weight alongside BDD as well, but we know that typically this isn't a core feature of the condition. So we always find it helpful to do a myth-busting exercise in BDD, because there could be lots of information out there that isn't quite accurate. And the first example of this is ideas around BDD being about vanity. So what we know is that this is false, and we know that BDD is absolutely not about vanity, and that it is a mental health condition that causes a significant amount of distress for the young person. And the behaviours that they might be doing, so things like checking their appearance in the mirror, wearing excessive amounts of makeup, or wearing certain clothes, isn't because they're finding this enjoyable. It's to reduce the extreme distress that they're experiencing, which doesn't fit with the idea of vanity at all. We also know that the idea that cosmetic surgery helps BDD patients overcome their concerns is false. What we know is through our clinical experience and through some research is that generally, no matter how much people might feel that correcting their appearance on the outside might help change the way that they feel about their appearance, this isn't something that has been shown to be effective, and that people can often find that they're really unhappy with the outcome of the surgery, or if they find that they are satisfied with the outcome of any procedure they've had, that this either isn't very long-term and can shift soon after the procedure, or that the appearance worries have shifted a little bit, where they've now started to worry about aspects of their appearance that they haven't quite been worried about before. And I guess it's also important to say that when we work with young people, they might often describe that a couple of years ago, they may have been worried about a particular part of their appearance, like their shoulder, for example, but that over time that can change as well, so that a new concern might be that they're more worried about their facial features. So we know that BDD can move around as well. We know that BDD isn't caused by social media, and we feel it's really important to highlight this point. Whilst there is unlimited access to social media content and the images that might come up, and highly edited and photoshopped images that set these really unrealistic standards about how the human body and face should be looking, and and we can be more exposed to this, and that can then make someone feel more sort of distressed about the way that they're looking, and increase some of the behaviours potentially that they're doing. So there is that element of the way that we might be interacting with social media. But what we feel is really important to highlight, that social media isn't the cause of BDD, as we know that BDD, like other mental health conditions, like, for example, depression and eating disorders and schizophrenia, has been around for much, much longer than social media has. So BDD is a Western problem is another myth, and we know that's false. We know that the way that BDD presents across the world is the same in terms of the time that young people can spend really worrying about sort of perceived flaws in their appearance, the extreme distress that they experience, along with the interference that these worries and these behaviours can cause in their day-to-day lives. It is the same. What we might see differences in is more of the content of those worries, and that might be more based on the social norms of a particular culture. So you might find that some cultures worrying about your skin or the shape or size of your eyes might be more common than others, for instance. But we know that in terms of the structure of BDD and the key symptoms, it's same across the world. Another myth is that there is no such thing as BDD in adolescence. It's just normal to worry about appearance, and we absolutely know that this is false. We know that whilst adolescents and sort of in the teenagers, it can be common to worry about your appearance, BDD is very different to this. And again, it comes down to the amount of time that an individual can spend worrying about their appearance and doing behaviours repeatedly to correct this and to bring this extreme distress down, and that the impact of BDD is and the interference cause is really significant. So it can stop people from going to school, it can stop people from spending time with their loved ones, and really we can hear some young people who feel really stuck in their and isolated in their homes or in their bedrooms. And this is very different to more usual appearance worries, where the young person might not as be impacted by these worries. So moving on to thinking about some of the common BDD-related worries that we can hear about. You can see here that there's quite a large list here, and quite a large range, going from some of the most common things being around skin and hair. And we often hear young people talking about concerns about their nose and parts of their body, for example, It could be sort of the size or shape of their legs, their chin, their eyebrows, hips. So it can be a huge range of concerns. And it can also be aspects such as, for example, sometimes people can worry about the way that they might sound, the way that their facial features might be moving as they're talking to other people as well. So there's quite a broad range there. And interestingly, what we know is that on average, young people can report about 5 to 7 different types of worries about their appearance. So it can, and these can sometimes change over time as well, or they can remain quite focused on those specific worries. We know that for some people, it can be, the worries might be more focused on a particular part of their body. So it might be that it's the size of their, or shape of their shoulders, or their nose, for example. So it can feel different to sort of having lots of worries, but more focused. I'm sorry, the slides are playing up a little bit. And on other occasions, sometimes people can describe thinking that it's not so much about a particular part of their body that they're worried about, but their more general appearance and how their features might come together and how their features might fit, and feeling that this doesn't feel quite right. So these worries can present quite differently from one person to another. And this is an example of some of the most common ones that we can hear about. In terms of common BDD-related behaviours, we can hear a lot about the idea of camouflaging, so covering up, and this can be through either the types of clothes that someone might be wearing. It might be through, if there's a particular worry about the size or shape of a young person's head, for example, they might be camouflaging using hats and scarves. We know that excessive makeup can come under this headline as well, of camouflaging. We know that comparing appearance to other people, and that could be anyone from sort of friendship groups to people that walk just down the road, to celebrities and social media influencers, for example. And we know that mirror checking can be quite a common BDD behaviour as well, people describing that they can really feel they're inspecting their appearance in the mirror for hours at a time. We know that grooming, excessive grooming, is quite a common BDD-related behaviour. So we can hear lots about young people saying that they might be using multiple products that do the same thing. So someone might be using 3 to 4 different types of moisturisers, or they might be using multiple different types of shampoos that essentially do the same, have the same effect. Reassurance seeking is another common behaviour, and this is where we can see also families being drawn in. So young people can say that they ask their parents or their siblings or their friends about how they might be looking, and this can range from whether they look okay to whether the other people can spot what the young person feels is a flaw in their appearance. We know that skin picking can also be quite common in BDD as well. And I guess the other key thing to outline is the level of avoidance that can be present in BDD as well. So this can range from avoiding sort of coming into contact with other people, and that could be by stopping going to school, stopping going to sort of work, or joining family occasions. It could be avoiding mirrors and all sorts of reflective surfaces. So it might be that people in their homes might not have mirrors up, and they've removed it because it's too distressing, or they've even removed, for example, pictures of themselves from around the house. So lots of a range of sort of behaviours that we can see in BDD. Another important aspect of BDD to understand is muscle dysmorphia. And this is basically a type of BDD where there's a strong sort of worry and preoccupation about the belief that someone's body might not be muscular enough or lean enough, or that it's too small. And in response to these worries and the distress that this can cause, young people might find that they're working out really compulsively. They're really checking their appearance and their muscle shapes and size in the mirror. they're using a lot of over-the-counter products and on a strict regime, for example, to bulk up, and they might be using protein shakes or these nutritional supplements that they might be getting online, for example. And the idea of not doing these behaviours, so the idea of, for instance, missing a gym session might be really distressing for someone, and they might become really upset at the idea of not being able to do that. So we know that this is an aspect of BDD that we're understanding a bit more about, and it's important to be aware of, and it's one that we see most commonly in males. So some facts about BDD. We know that BDD is a really common mental health condition. So around 2% of teenagers we know have BDD. And this makes it more common than mental health conditions like schizophrenia. We know that there are more females than males in the general populations that have BDD. However, in more specialist clinics, this number might be equal. So an equal number of males and females might be assessed and treated. We know that BDD can start at any life point at any age, but most often we see that the starting point of BDD is before the age of 18. And we also know that other conditions can be quite common in BDD, like depression and anxiety. And it's important to outline that there are some particular difficulties and risks that are common in BDD. And some of these, as you may have heard during the talk, is around being housebound. So it might be that because of the distress experienced from the appearance concerns, that young people find to have a way of avoiding this might be to not leave the house, and that they feel less anxious in that environment. And this can mean that they're unable to go out to the shops, spend time with their friends, and sometimes even feel restricted to certain parts of their house as well. So they might find it difficult to step out into the garden too. We know that dropping out of school can be quite common for young people with BDD. And it can be really hard to sort of focus in the school environment and affect learning as well. And eventually, when BDD isn't treated, it might mean that it's difficult for the young person to stay at school, and they end up leaving. We know that there are sort of high rates of suicidal ideation, so thoughts about sort of not wanting to be around because of some of the difficulties that they're experiencing. And it's unsurprising that depression can be quite common as well as self-harm. And we also know that there could be a particular risk around finance. So this is when young people feel the urge to buy products to help correct some of the flaws they perceive in their appearance. And this might also include things like cosmetic procedures, certain outfits, certain expensive products. And this can all mean that they might find themselves getting into debt, or it might put pressure on their families and finances as well. So another question is around, why do people get BDD? And there's lots of research being carried out to help understand this question a bit better. And at the moment, there isn't a sort of understanding of the exact reasons of BDD. But what we do know is that there's, like other mental health conditions like depression, for example, or social anxiety, that it's likely that there isn't a single cause for BDD, and there are lots of different factors that come together that might make someone more vulnerable to this condition. So these can be things like biological factors and environmental or psychological factors that might play an important role that we'll move on to thinking about. But what we do absolutely know is that BDD isn't anybody's fault. So it's not the fault of the young person, it's not the fault of their family, their parents, or their friends, for example. And we feel it's really important to highlight this point, because lots of people and with BDD and their families can feel responsible for the condition, and we know that this isn't the case. So some of the things that we know can make someone vulnerable to developing BDD might be around sort of biological factors, so genes, brain chemicals, certain sort of family history presentations. So we have some research showing that BDD can run in families, and that if you have a relative with BDD, for example, your chances of developing BDD might be higher. And also if you have a family history of mental health difficulties, that also a risk to developing BDD might be a bit higher in that scenario as well. There aren't any genes identified that specifically are linked to sort of the cause of say BDD, but we know that there are likely to be multiple genes at play. And we also know that there's a role sort of reduced activity of certain brain chemicals like serotonin that might make someone vulnerable to BDD. In terms of the more environmental and psychological factors, we know and we hear quite commonly about sort of teasing and bullying and stressful life events that have happened for young people. So moving school, losing a loved one, those kind of situations we know that might increase experiences of stress and increase vulnerability to BDD. We know that there are certain types of personality traits like perfectionism that might be more commonly reported in individuals with BDD. And this might be a factor that might be driving appearance concerns. And a specific sort of factor associated with BDD vulnerability might be around aesthetic sensitivity. And this is basically the idea that, similar to musicality, people might differ in their aesthetic skills, and they might place more value on appearance. So they might then be more conscious about their appearance and more aware of variations in their appearance as well, which might make them then more vulnerable to the condition. And this particular idea is supported by the fact that lots of people we see in our clinic with BDD either have an educational background or sort of an interest or a desire to pursue careers in sort of the arts and design sectors. And this has very much been our sort of experience in the clinic. And we've seen lots of talented work produced by the young people that we've worked with. And I've included some examples here of some of our young people who have contributed bits of their artwork and designs to some of our information sheets and books. So we're always really grateful for that and always really love to see some of this talent. So a key question is, why is BDD underdiagnosed? So one explanation to this might be that people might be seeking treatment for BDD outside of mental health care settings. They might be going to places like orthodontists, cosmetic surgeons, dermatologists, rather than seeking help from a more psychology setting. And this might be because people in those settings might not be as aware of BDD, and the idea that people might be thinking of an idea that if they fix their appearance, that their distress and their worries might sort of reduce or disappear because of this. So I think it's very important, and it's an important line of work that we're thinking of in our clinic in terms of raising awareness of BDD across lots of different settings. We know that clinicians can sometimes be unfamiliar with BDD, and this can contribute to BDD being underdiagnosed. And they might interpret some of the symptoms that young people are reporting as fitting with other conditions like depression or social anxiety disorder, and therefore might be young people might be misdiagnosed with these conditions, and BDD is missed as a result of that. We also know that young people and individuals with BDD more generally find it really hard to talk about their appearance concerns unless they're directly asked about it. And this is for lots of different reasons. So it might be that they're worried about being judged, about being vain when they're talking about worrying about their appearance. It might be that they're experiencing a lot of sort of embarrassment and shame when they're describing their concerns as well, which can really make it hard to open up about these difficulties. And I guess another idea is that they might not want to draw attention to the aspects of their appearance they're worried about as well, and this might then make it less likely that they're going to share these difficulties and mean that the condition goes underdiagnosed. We also know we've also heard the idea that BDD symptoms can be seen as being normal, a normal part of being a teenager, for example. So young people might try to open up about their concerns, but they might find that because the other person isn't perceiving the flaws in their appearance that they're seeing, that these concerns aren't as picked up because of that. And again, it can be seen as being a part of being growing up as a teenager, which we know isn't the case. And these are some of the reasons why BDD has remained underdiagnosed. So how to get help for BDD? Here's a bit of a sort of a guideline on a pathway and how you can access help. And essentially the first point of contact is likely to be your GP and asking for a referral to your local CAM service for BDD assessment. Or if you're closer to 18, that referral might go to IAP services. And if you're referred to CAMS, assessment and screening will happen at this point, and that will be an indication of whether BDD is confirmed or whether BDD isn't a good condition to understand difficulties under, and alternative recommendations will be made. But if you are on that BDD sort of confirmation pathway, then intervention will either be offered in your local CAM service, or it might be referred on to a National Specialist service, and that's where you'll receive an assessment and an intervention will be offered at that point if that's appropriate for your needs, and you'll be on that pathway until you receive your full package of treatment and enter the follow-up phase of your treatment. And that's a part that we'll sort of talk about in a bit more detail later on in the talk. So thinking about how BDD is treated, the initial part is thinking is the assessment process, where young people come and meet other mental health professionals, and where they'll be spending some time trying to understand what some of those difficulties related to their appearance concerns are and how that's affecting them. And similar to OCD, a modified version of the Cybox, which has been created for young people with BDD, will be used to run through a checklist of questions that help identify the key areas of difficulties. And once you sort of go through this process and spend some time answering these questions and thinking about your BDD as carefully as possible, this will indicate a score that ranges from 0 to 48. And we know that the higher the scores, the greater the severity of BDD symptoms can be. And as a part of this process, we'll also find out about the history of BDD, so how it developed and whether there are any other difficulties that is going to be helpful to hold in mind, and also thinking about any sort of family members who might be in the past or currently experiencing mental health difficulties. We know that in terms of treatment, NICE recommends that the most effective evidence-based treatments for BDD are cognitive behaviour therapy with exposure and response prevention, as well as SSRI medication. As we've discussed, cosmetic surgery for lots of reasons is not recommended, because we know that that's not an effective treatment that provides long-term good outcomes. And in terms of the structure of CBT for BDD in young people, this usually involves 20 weekly sessions, with exposure and response prevention being the key ingredient in treatment that we focus on. We know that homework tasks can be really important to support progress in treatment and give the young person opportunities to practice what they've learned, particularly ERP tasks, in their own environment. And we also have sessions joined by parents, so that they're a part of that learning process, and they really also learn about how exposure and response prevention works, so that they can really support their young person outside of treatment. And we spend, as you can see, the first few sessions thinking about psychoeducation, so learning about BDD. We then move on to fighting back with ERP, which is the core component of our treatment package, before spending the last couple of sessions on relapse prevention and planning for any sort of challenges that might come up along the way. We have regular review points at certain sessions, so sessions 7, 14 and 20, and then once the young person's in follow-up, we will then review at those sessions as well. So very quickly, psychoeducation will involve learning about BDD and anxiety, and how anxiety can present itself in BDD. We sort of formulate a maintenance cycle of BDD and really try to understand what some of the beliefs are in this process, and how life experiences may have contributed to this. And most importantly, thinking about what are some of the triggers and what are some of the behaviours that are keeping BDD going. And we then move on to thinking about listing some of those behaviours in the hierarchy format, ranging from behaviours that you can't imagine quite stopping at the moment, versus behaviours that might be a starting point to start challenging BDD with. So in terms of our formulation, we spend some time thinking about some of the negative thoughts that the young person might be experiencing. For example, here we hear about a young person talking about their worries around sort of the size of their forehead being too big, and what this will mean is that others might be disgusted and won't want to talk to them. And we think about the emotions that the young person is experiencing, and often we can hear about anxiety and shame being quite common in response to these thoughts, as well as hopelessness and anger. And then we think about some of the behaviours that are carried out to reduce these feelings and give that very short-term relief to that anxiety or distress. And we can hear about sort of avoidance and camouflaging behaviours, really focusing on appearance through sort of mirror checking. And also we can hear that this is also the point that families can find themselves being really drawn into BDD through reassurance seeking and avoidance, for example, of parents or siblings doing things for the young person because they feel unable to. So this is more the maintenance part of the cycle, where we think about what are some of the factors that are keeping BDD going, and what are some of the situations that trigger this response and this cycle. And in session, we'll also think about some of the life experiences and how things like being bullied or teased at school have influenced beliefs around appearance as well, to understand why there might be that particular focus on appearance, and why certain situations are quite triggering for a young person. We then move on to fighting back with ERP. So as you will have heard, exposure is all about sort of facing the fear with the perceived flaw visible, if that's possible, and then preventing the action, so fighting the action and those BDD safety behaviours, things like checking, avoidance, camouflaging, for example. So a typical example might be going to the shop as part of the exposure without wearing a hat, which is a response prevention in combination that we know can be quite effective. And again, we take a very graded approach with this, so that it might be that going to the shop without your hat, for example, might be a big step to take. And we might sort of break that down into thinking, what part would it be just sort of initially leaving your home, walking down the road, how much of your head might be exposed, for example. And the goal of ERP is really to reduce the impact of these behaviours and the distress and the interference with daily life that causes. And we do this in a really gradual, planned and repeated way. So basing it on your hierarchy of appearance-related concerns, planning out what the exposure and the behaviour to be resisted will be, and staying in that situation until anxiety has come down over time without you having to do a BDD behaviour, and really repeating these tasks outside of the sessions, because we know that practice is a key component of successful ERP tasks. So why do we fight back with ERP? if we think back to a time, for example, where we face a situation that we feared, for instance, going on a roller coaster, we know that the first time we do it, we feel really anxious and there's an increase in our anxiety. What we know is that over time, without us having to do anything, that will come down. We know that when we face that situation again for the second time, the anxiety still might be there, but not quite so bad. And it might not take as long for it to come down naturally. And by the third time, we know that it's not quite as bad again. And if we keep going with that principle, we know that, and we face that situation over and over again, at a certain point, we'll no longer notice that feeling of anxiety at all. And it will become a situation that isn't anxiety provoking to us. So it's the principle that we know that anxiety comes down over time all by itself, even when we stay in the situation. And that the more we do something that is fearful to us, the less anxiety provoking it becomes, and anxiety comes down much quicker. So fighting back with ERP means that we have the opportunity to demonstrate that anxiety and that discomfort can come down over time. It helps us gather evidence and challenge some of the beliefs that the young person might hold about appearance. So beliefs around no one will want to talk to me unless I look better or I look different, for example. And ERP can really help build self-esteem in ways that also can be helpful outside of worries about appearance concerns. And the principles of exposing yourself to fearful situations and resisting and fighting the action can be relevant across the board in your day-to-day life as well. So quickly going through relapse prevention. This is the part of treatment where we know that it's helpful to sit back and take stock of what has been most helpful, review what's been learned and what's really standing out for the young person, as well as thinking about what are some of the upcoming events that might be stressful that we need to plan for, and really sort of create a bit of a blueprint of what the young person will do to build on their progress in a self-led way, and what support that they might need from their family, for example, to keep their progress going. And then we come back and review at the 1, 3, 6 and 12 months points of treatment once weekly 20 sessions of CBT have come to an end, and have also a quick check-in on BDD symptoms as well. So similar to what Sasha outlined in her talk as well, there might be some barriers to accessing treatment for BDD. And that might be, as you know, we've covered that BDD is underdiagnosed because there are difficulties with who might be aware of BDD at the moment. So it might take time to recognise BDD symptoms and to diagnose, to get the diagnosis and access treatment. We know again that waiting lists in CAMHS services can be long. So once you've been through sort of the process of attending your GP and being put on the CAMHS pathway, there might be a wait for that assessment and for that treatment to start. Clinicians might not be aware of BDD as a condition and CBT treatment for this condition in comparison to other conditions like social anxiety, for example, or depression. So that might make it a bit harder to access treatment as well. And also it can feel, again, as Sasha was saying, it can feel scary to do ERP, and before you get to ERP it might feel scary to talk about some of the appearance concerns and difficulties that you're experiencing, and then to move on to thinking about facing some of those fear situations. And I think it's important to say here that your clinician working with you would be really open and happy to hear about some of these worries and concerns, so that they can support you in thinking about how they can make treatment sort of more accessible, and what are some of the measures that they might be able to put into place that makes facing ERP less anxiety provoking initially. So it might be that tasks might need to be broken down in a bit more detail. There might be that you might want to go at a slightly slower pace, and all the while making sure that that's not quite feeding into the avoidance of facing the situations, but helping you engage with that ERP process that will eventually help break and weaken that BDD cycle. And you're probably quite familiar with the great BDD Foundation OCD Action websites and the great resources that they have on these available on the websites. So there's lots of information, for example, on the books that might be helpful for you and your families to read on. There's lots of sort of good information on the documentaries and TV programs that have been made on BDD that you might want to see if you haven't done so already, and lots of information on how to take, for instance, talk about BDD to GPs, for example, and some resources on there that you might find helpful to go through. So in terms of key take-home messages, we would say that BDD is a very common mental health condition in young people. We know that it affects 2% of adolescents. We know that BDD can cause a significant amount of distress and interference in a person's day-to-day life. We know that GP services and CAMHS services can be really helpful in letting you access, supporting you to access treatment for BDD. And as difficult as this might be, it's really helpful to be able to talk about as openly as you can about some of the symptoms that you're experiencing with mental health care professionals or your GP, so that they can link you into supporters as quickly as possible. And just finally, to say that you're really not alone. The BDD, like we've said, is a very common mental health condition, and there is help available out there. So thank you very much for taking the time to listen, and sorry for the technical issues during the talk.
Thank you so much, Elif. That was a brilliant overview of BDD. We have got a question in the Q&A panel. If you wanted to kind of check it out and answer that one, I can.
Should I stop sharing my screen? Right.
Yeah, you can do. Yeah.
Okay. So it's from, can you fully recover from BDD permanently, so no longer needing medication and treatment? So this is a really interesting question, and I guess what we know is that our treatment can be effective for BDD, and lots of people can find that they're reducing their symptoms and the impact of BDD. And eventually it might be that their symptoms have remained low for quite a long time, and this is the point where they might want to consider stopping medication. And I guess it's what we typically advise is that following treatment, during the follow-up phase and potentially beyond, if medication is found to be helpful, that this might help sort of further apply some of the skills that you've learned to develop build on your progress in that more sort of independent, self-led way, and to review then whether that might be a good point to stop medication. So recovering from BDD is, as we know, is something that we've seen, and I guess it's also holding in mind that it might be a bit of a longer process maybe than sometimes people might imagine. It might go beyond the 20 sessions and the 12-month follow-up period, where you're finding you're using your skills more often throughout your day-to-day life and really finding that progress and that you're building on that. Yeah, so that, and I guess these are helpful questions to also bring to the review part of your treatment process as well, to consider.